Masiluleke, 067, also Gauteng, the Health Project. Krista Dom and Denishle Tabete, welcome. I hope you enjoyed sitting through this. You've been here since yesterday and that you've learned a lot. So we look forward to your presentation.
Good afternoon. We're going to start by showing you a clip and then start our presentation.
And before the clip starts, we just wanted to verify we're not from Propel Foundation, and we're also not from Gauteng. We're from KwaZulu-Natal, and that's why we have the supplement to give you, and it should be very, very clear. But yes.
KwaZulu-Natal is one of the 9 provinces in South Africa. But as much as it is beautiful, the culture and the people are still having to deal with a lot of challenges inherited from the apartheid regime. Poverty, crime, rape, HIV and TB, we're still dealing with those things.
What Zinni does day in and day out is she works as an ARV counselor, and she does it in the area of the world with the highest prevalence of HIV infection, one of the places with the least resources available. So talk about taking on a challenge.
I met Zinni at a hospice in Durban, and I was going there bringing some food to a hospice support group. And when I arrived, the whole group were some of them in wheelchairs, some of them in stretchers, others sitting in chairs, and there was this very thin woman in the back seat singing like an angel.
When she met me, I was straying from being in hospital with meningitis, which is a headache that usually gets to trouble people with end-stage AIDS.
In KwaZulu-Natal, every other person you look down the road is positive, negative, positive, negative. Every other adult walking down the street is HIV infected. The clinic here, pregnant women coming for antenatal services, 60% of them are infected. And of those, up to 30% without any intervention are going to deliver positive babies. We have 1,500 nurses trained that join the workforce here in the public health sector every year. 1,500. 2,000 nurses die from AIDS every year.
We have a huge shortage of human resources. There are not enough doctors. There are not enough nurses. There's not enough resources for basic care. You can imagine how impossible or difficult it is to roll out an ARV program to a system that is not working for basic things.
The good news is that medications are now available to treat HIV infection in the public sector in South Africa. The problem is that there still is not sufficient access to those medicines.
If they don't start the treatment as early, they have to wait till a long queue for the doctors for about a month or 2. Some of them, they die before they even see the doctor for the first time to initiate the drugs.
Mrs. Tabet helped me because I was taking so long. I think they said we're waiting for 3 weeks or 1 month to come to see the doctor.
We felt that there wasn't enough time because the CD4 count was going down and she was ill.
How do you feel about Mama T?
She looked at me. Every time she phoned me, she said I must drink pills. I like it so much.
Okay. Usukhala uzophila. Okay, uzophila. Usukhala.
We leave the challenges. We know the challenges of the systems we're working in. We need some sort of intervention, some sort of innovative intervention that can allow us to spread our wings.
So Project M, which is what we're presenting today, we are partners. I teach at Raquel Foundation from Johannesburg. Project M is trying to look at those innovative ideas that I had mentioned in the video. But before those interventions actually have to look at addressing issues like why we're in a country where everything is free, testing is free, treatment is free, and yet we have 25% of people who are needing to access these services are accessing them. 25% of South Africans have only tested when treatment or HIV testing is free. We are looking at people who are coming to care very late, even with the medications. 30% of these patients will die no matter what we do because people present late. That is why we have to look at interventions that will actually address this gap between what we have provided for the patient that is for free and why it is not being accessed. So why don't South Africans test and start treatment early? That's the question we should be asking ourselves when we have everything available. Awarenesses that we see in our communities are really things like prevention methods that are adopted from other cultures and other communities that do not work for us as South Africans. And also awarenesses that are ineffective and inappropriate. Billboards that talks about things like love life, get attitude. It does not tell anybody where do you get attitude. It does not allow you to access any help. It doesn't give you direction as to where exactly do you go for such. If you want to get this attitude, where do you go? If it's not me, it's just not for me. I mean, these billboards are not really directly talking to the problem and talking to the people we are trying to address. We're seeing these billboards in the communities, in Zulu communities, written in English and not being really related to what action can someone who's reading that do after that. That is why we had to come up with something that will have to be innovative enough. Promoting the replacement of condom in the shower, confusing people. I mean, really, this is ridiculous. We are living in a country that is a ground zero of the AIDS epidemic, and we haven't actually taken a few steps back to go and see what are we not doing right, what are we doing wrong, because these services are available, but at the same time when we are introducing those things, we come up with such confusing messages from higher people that are really going to be taken seriously and produce such. Chris has spoken a little on the video that 60% of HIV positive mothers, young women, and as has been presented in this room, young women, teenagers, 60% of those who come from antenatal are HIV positive. So we as I teach on the ground level in KwaZulu-Natal had to sit down and look at what is it that we're not doing right? Why are we designing programs that are not addressing the issues that we are? The problem is we did not, all the programs that are there are not linking the chain of care to resulting to saving lives. We have a problem of people dying from HIV for 3 decades now, but we haven't even actually addressed that because all the programs are segmented. Even in the hospital, there are people who know that my job description is just to do this. It cannot work so well. So we have to look at a strategy that will address effective awareness. We have to look at scale-up testing. And at the moment, you have to go to the clinic. That can never be scaled up. Earlier access to treatment, it is based in our hospital. Nobody wants to go to the hospital. We have to go and look at how we're going to translate those things to actionable items where we address the real issue. Scaling up of antiretrovirals. We are running doctor-centered programs, yet we do not have enough doctors. We are running programs that are based in an institution, yet we don't have enough facilities to provide this counseling. Confidentiality is being preached everywhere, and yet there is no counseling room that addresses that. We have to give good care. We have been speaking in this room that people are demotivated, nurses are overwhelmed. Who can see 20 or 40 patients in a day and still be excited to give HIV positive or negative results to a patient that comes through? Adherence is one of the issues which actually has to result in retention into care and end up saving lives. These are the kinds of things that we need to look into them and address them, each and every one of them. Hence, we are having something called Project M that looks into all those issues, and Ed, Crystal will be taking over from here.
Project Masiluleke is one initiative that we're involved in that looks at that chain of care that's broken and doesn't result in saving lives. It results in needless loss of life, in fact. Project M uses mobile phones, innovation, and new partners to create this chain of care that does save lives. There are a lot of things that go into it, but again, we have a shortage of staff. We don't have enough doctors or nurses. We don't have enough counselors. We don't have the facilities. So what aspects of that chain of care that we can't eliminate the human need, but what parts of it can we use technology? What parts of it can we use that can be scaled up rapidly where capacity is very short? So what kind of tools are needed? Well, South Africa and Africa in general has excellent cell phone coverage. In fact, if you look at these countries on the right, South Africa has the greatest coverage, and it's estimated by this year that 100% of households, even in rural and poverty-stricken communities, will have at least one cell phone, but the majority of individuals do have a phone. So let's exploit that. It's the internet in the West, but here it really is cell phones that we can use. In South Africa, we send 30 million please call me's every single day. And in those messages, previously, a few years back, it was just blank, and there were 120 characters of unused space that was determined by Vodacom to be commercial real estate. And so Prakelt Foundation demonstrated how you can do that for profit. They demonstrated how you can do it for service, and then they went back to Vodacom and said, okay, now donate some of your inventory, let's do some good. And they said, let me think about it. No. So they went then next to MTN, and MTN said, that's a great idea. We'll give you 5% of our inventory of those 20 million messages and let you do with it what you will. And this is what they did. The idea was to use cell phones and send key messages on HIV and TB to an individual's handset that are in local language, and then drive them to somewhere for an information source. And we chose the South African AIDS Helpline. So MTN, again, giving 5% of 20 million messages means 1 million messages going out in every single one of the 9 provinces every single day. How did that work? Well, it worked. It started in October. You see where the bars went up? A 300% increase in calls coming to the AIDS Helpline from day one, and that's been sustained since October of 2008. When they stopped it to do a quiz, it went right back down to 1,000 calls a day, started again, 3,000 calls a day. The call center was overwhelmed and didn't have the staff and capacity. The questions we were driving them, they didn't have the training for. So our organization went up and trained the AIDS Helpline on how to field these questions about, should I use immune boosters or should I be using ARVs? How do I have a child? My partner's positive and I'm negative. All these kinds of issues that we were driving calls into the center. Great, they're calling it an AIDS Helpline. Is that going to result in persons testing, learning their status, getting the treatment they need, or engaging in preventive measures and saving lives? That's our question. So they call a helpline. So Project M, we wanted to, how do we scale up testing? We know that only 1 in 4 people have ever tested, even though it's free, widely available, and everybody knows where to get it. So how do we do it? Is there another option? So we thought, actually this idea wasn't our own, but we went to an artist, musician that some of you may have heard of from Ghetto Rough called Zola. We went to a lot of different people, from grannies to children, teenagers, said, who do you trust in the community? And they said, oh, Zola, he's doing such great work. So we went to Johannesburg and talked to Zola and said, hey, we got this great idea. Why don't you put on concerts? And at the end of the concert, we'll have a mass HIV testing and everyone will test because they all respect you. And he said, that is the stupidest idea I've ever heard. He said, and I know it's stupid because I tried it. And after a big concert, 7 people came to the tent to test. And trust me, when I tell you, all 7 knew their status. Nobody comes to learn they're HIV positive when they come to hear music. What we really need, we need a self-test that people can use, be empowered, take when they want it, use it when they want, and not have to go to the clinics where it's their auntie who's the sister in charge, it's their cousin who's queuing, and because of that stigma. Are we ready for that? Initially, the complaints were, what? You can't self-test like a pregnancy test. People are going to jump out a window. They're going to hang themselves from a rope. You need that sensitive counseling from a public health servant who just saw 30 people in a big room where they called you like, you 5, go that side. You can go home. Confidential, sensitive counseling for someone who has suicidal ideation? I don't think so. People really want to be empowered. So how do we do that? And is South Africa ready? Well, they say it's currently illegal to give out a test kit without VCT, voluntary counseling and testing, pre and post test. I promise you, if you go into town and walk into a pharmacy and ask for an HIV test, you're going to get one in 75% of the pharmacies. You're going to plunk down anywhere from 30 Rand to 200 Rand, and they're going to give it to you with nothing and not even any instructions. This is 1 of 4 we went into. We walked out with a test kit from every single one in Pietermaritzburg. Where else can you get a self-test? If you work in a clinic or hospital, you can steal one. And because Healthcare workers are stealing them at such a rate, we lock them behind 3 closed doors. There's where they are. So an infectious disease specialist at Gray's Hospital in Peter Marisburg can't even get a kit to test a patient. She said they're across the hospital, locked behind doors, because everyone's stealing them. So instead of putting them out in the parking lot on accident, which is what we should be doing, we lock them up. This means that millions of South Africans who need that test can't get them because they don't have the money to go to a pharmacy, they don't have the transport fees to go to town to the pharmacy, they don't even know they're in the pharmacy, and they don't have a job in a hospital where they can steal it. So the people who need it the most are not able to self-test. So we thought, if we had a self-test, what should it look like? What size should it be? What color should it be? Should it be free? Should they pay for it? Where should you be able to get it? So we went to the ground. We went to 3 communities. We went to a rural, semi-rural, and a peri-urban area and asked people what it should look like. So this is just one of multiple focus groups finding out, would you use it? What do you think? What kind of support should it need? 85% of the men said that they wouldn't test in a clinic. 78% of men said they would prefer to test at home. They said the clinics are full of people I know. I don't want people to see me standing in queues. I want to be in private and secret. I wouldn't visit a clinic because of the undignified way healthcare workers handle the issue of patients. After a nearly year-long process and back and forth with Frog Design, an international design firm, we came up with this kit, which was the first prototype. And we have different images of South African celebrities that we're going to show you who said, I know mine, learn yours. It was designed specifically for low literacy communities, and we had groups of people try this and see, can they test accurately and can they interpret the result appropriately? And should we give support? Of course patients need support. We're not suggesting they don't. But the clinics are overwhelmed and people don't want to use them. And if that's a barrier, let's try something else. Give a free, toll-free line. You can call it and get counseling if you want it. The responses were, I think people would love this kind of test. It's important and this system can be easy. We're looking forward to them. You're very late. I've watched so many of my friends die because they're too scared to go to the clinic. This gives people the choice to test in private, call a counselor if they want, only if they need help with instructions or they want counseling. Counselors loved it. They can sit now stacked right next to each other, and it's confidential counseling because they're in a room together and someone's accessing it remotely. Great, people test, they go into treatment. There's a brand new study that was released at the retrovirus meeting on the 18th of February that said that it seems like a gimme and everybody knows it. If you test, you're more likely to enter care. Well, this study confirmed it. Early testing in an inner city community resulted in more people entering care and starting treatment earlier, as evidenced by a lower CD4 count. So while testing by itself isn't the answer, it's a start, and we know people enter care earlier. They have to stay on care once they get on care. How do you do that? Can we use technology? Well, again, our partners in Gauteng, Health Foundation, developed a system called Text Alert. They piloted it at the largest ARV rollout in the country, which is at Helen Joseph Hospital, which is fully supported from overseas USAID Right to Care. And they went to patients and said, would you like a reminder on your cell phone? Simply to say, you've got a clinic appointment in 7 days. You've got an appointment in 1 day. Where were you yesterday? We missed you. They thought there'd be some stigma. Some people would say agree. Almost everyone said, yes, I want those appointment reminders. There's good evidence to show that adherence to clinic appointments leads to retention in care and treatment adherence. They piloted that at a funded site, and we're going to pilot that at the first government site in KZN. The majority of our patients and the patients you saw in the video are dying from tuberculosis. South Africa has the worst national TB treatment program in the world. 25 out of 53 of our districts in this country have a treatment completion rate of less than 50%. This means we make MDR. This means we make XDR. MDR has a mortality rate of 60%, XDR of 85%. Healthcare workers in KwaZulu-Natal are 6-fold more likely to develop drug-resistant tuberculosis than someone who doesn't work in the public health sector. TB is an absolute emergency. Patients don't finish their treatment. What can we do to help that? This is what it looks like in the hospital. 40% of the patients have tuberculosis, 50 to 80% have AIDS. We have a new idea we want to launch in the next couple of months called Text Alert TB. Simply sending monthly reminders to a patient's phone to say, go to Pata Clinic and collect your medication. You should be feeling better by now, but you have to finish this or you can develop a dangerous tuberculosis. Send it in local language. That sounds actually a little boring to me, but I think it would work. Can we make it sexier? How about if we go to the patient in the queue who's identified as co-infected and say, here's some different cards of celebrities. Would you like Alicia Keys to send you a text message every month and remind you to take your treatment? How about Ishmael? How about Bongani Fossey? Oh, give me Bongani. You're gonna get a text message every day, or maybe from John Legend that says, John here, hey Tembi, nice job on finishing 1 month of treatment. It's a little gimmicky, but hey, I think it's cool. And in a country with the worst treatment program in the world, let's do what we can in something that's truly scalable, and it's cost effective too, and it's fun. So Project Masiluleke again, this chain of care, you can't replace it with a cell phone. You can't replace it with a self-test kit. There are lots of components, and the majority of our work that I teach is roll up your sleeves, get dirty, train, be in the sites, be in the clinics, form relationships and linkages. There's a lot of work we do, but we pulled out the aspects of this chain that we could make something very scalable and use technology and use a little bit of fun and new ideas to get around the challenges. And these things are highly replicable and scalable. Again, another thing that's a theme is work for us. We came from private and we work fully with the Department of Health. We believe because the majority of South Africans get their health care in the public health sector, that's where we need to be. Where the challenges are the worst, that's where we have to be. And we have to make it work in the partnerships. Department of Health can't do it alone. Not with multiple different departments or NGOs. We need to look to all kinds of different partners. And the very last little segment I want to show you is just an idea of how diverse and how creative we can be, the kind of partners that we do engage to raise awareness and get people to get the care that they need.
Sanibona. Igama lami uMalik. Mina ngifuna ukusikhohle kancane nge-TB. Sike sijabule sicule nje sonke sibe mnandi. Everybody should know they can have a second chance in life. My name is Malik Swane. We're from a record company called Get Around. What we're gonna do, we're musicians, right? So we felt we can spread the message through our music, but we needed to see what is going on before we preach it to other people. So now, say what? Live your life.
I just felt, you know what? I need to go do this. This is what I'm supposed to do. Because I lost a sister through this thing.
Now, live your life.
I'm shocked because where I'm from, the stuff is not shown to me. We don't read about this kind of stuff.
Because like most of people, they die nowadays and they die without knowing what kills them. So it's important for people to test now. And I think it's from me, Fisto, it's Gumshev. I'm also ready to check.
So now, live your life. So now, live your life. Let everybody go.
Thank you.
Thank you.
What this project shows is that we have to use everything, technology,
Pop culture effectively to get the message across. Thank you very much. Very inspiring. Questions? Graham?
Let me ask this because it's obviously a very impressive project. But you're saying that there's lots of testing that goes on in clinics. I mean, we've been hearing over the last few days that testing in clinics has seen heart go up, use of heart, has seen people staying on antiretrovirals and so on. You're suggesting this is not so?
No, actually, we should be extremely optimistic and excited about what's happening with treatment. With what's going to happen in April, with lowering the requirements and more people can get on treatment, it's extremely encouraging and exciting what is going on. 2 years ago, less than 10% of South Africans lose their status. Now 25% do. So we have tremendous gains and things that are happening positively. But if you're on the ground looking at it every day, I'll tell you, the lifts are packed and you can't even ride them. You have to take the stairs because trolleys are filling them going to the morgue. As many patients who are getting on treatment, the majority are dying at home without knowing their status. We're not meeting the needs. And right now, we're not meeting the needs with the CD4 count entry level of 200. When it comes 350, I'm telling you, it's going to be an extreme challenge. So we're looking at things not to replace the current system, which is making positive gains, but to add something complementary. How do we go from 10% to 25%? It's things like Project New Start and different options where we thought, you know what, stigma's so bad people won't go to the clinic. Then you put a cardboard box and offer testing in the middle of a taxi ride for 25 Rand and people are queuing. People want another option. So all we're doing is offering a dignified alternative option, not to replace, but to augment and try to get us to universal testing because we're a long, long way from it.
Question?
There's just questions that arise out of the evaluation and just the testing kits, those self-help testing kits are incredible, it makes perfect sense. Just can you talk to us a bit about the reliability of those tests? It's come up in the evaluation, and I'll ask two questions, one after the other. I'm not sure the texts that people get. You know, if people are living on less than 20 Rand a day in South Africa, many people, isn't the costs of telecoms a barrier to their use by this section of the population? If
100%. So I'm going to answer your second one first.
Okay.
The free National AIDS helpline is free if you call from a landline, and you're going to pay with your minutes if you're going to call from your cell phone. So there's like a 80% drop rate of persons who call, get the recording and say, you're going to pay your call, they put it down.
Yes.
So we really have not made universal access to this information through the National AIDS helpline. And we're working with, and certainly don't you think telecom should be making lines available for people to call from their cell phones or do something for it. So that is a huge shortfall. Having a truly accessible helpline that people can call for free. Yes, agreed. This answer to your second question, it's not a new technology. The test is not. The kit is simply packaging it together with instructions for low literacy populations that allow you to test on your own at home, irrespective of whether you have a standard 2 and you're a 60-year-old male living in rural KwaZulu-Natal. So the tests that were inserted for our first focus groups is the rapid oral swab test made by OraQuick, and we're doing a feasibility study where we're going to use 2 finger pricks. The 2 tests that we chose are 2 that are currently approved and approved by tender by the Department of Health. We're using only tests that are approved by the MCC and currently in active use in South Africa. The test itself is not the technology. It's just the packaging of it and distribution and promotion and information around it that make it the kit. It's not a new test.
Okay, thank you.
Michelle?
The reliability of those tests.
Okay. The reliability of those tests, these are the exact same tests we're using right now. There's no different reliability.
Used by a layperson.
Oh, okay, okay. So they're about 99% sensitive and specific. So the sensitivity is how likely am I to pick up a true positive, and the specificity is how likely am I not to pick up a false negative. So the tests are extremely reliable. However, we do have circumstances where there is something called an indeterminate test. So what we do in South Africa, if you go for VCT, and 75% of you probably haven't, is you get tested first, and if that's a positive, they do a second. If that comes out negative, they're going to do an ELISA test, or they'll go on to do PCR or Western blot to determine. So if there's unreliability. Also for some tests, you can get like a faint line that isn't clear, and that's an indeterminate, so it needs repeating. These tests all have storage requirements, they have expiry dates. The oral swab, the reason we don't want to use that OraQuick is because it has a high false positivity rate, and that's why the Department of Health stopped using it, and that's why we're not using it in our next go round. Another problem with it is it's heat labile. Once it gets above like 32 degrees, it's not functional. Like that doesn't work in Africa. So there's another company we're looking to. There's only one company in the entire world that has a rapid oral swab test. So there's another company that has one in development. It's going to the FDA. It's not approved here in the MCC yet. But when it is, we need a heat labile, a very easy to use oral test because people would prefer oral swab rather than a finger prick. But our next round is going to be finger prick only.
Yeah, but also in addition, there is nobody who goes for testing once and take it as a serious issue. You will go testing 3 times, and going through 3 different clinics, you finally say, okay, maybe they're right,
Francis and then
Yes,
Andre.
do you have ideas as to how one can put some real political pressure on, let's say, A, Vodacom to open up, and B, Telcom to make those lines? Because it seems to me that there's a, whether you're going to survive or not depends on which cell phone you use.
If anybody in this room can tell me how to get to Telcom, then we meet afterward. But as far as Vodacom, they saw this great launch and press conference that MTN got. Finally, they're like, Raquel, can we get on board? So Voda came to the party only 2 years down the road when they saw MTN get fabulous lauds and a big launch. Saw the yellow wall up like, wait a minute. So they came to the party, and we need to give them something that's unique and their own that they can call their own. That's great. Get behind Text Alert TV. We'll give you all the press you want. Help us out. Come to the table. Telcom, if you've got the ideas, you've got a phone number for us to call, please, let's meet after lunch.
I'm trying to understand your information chain. How do you have the phone numbers of people to SMS?
Okay.
But also, once they've tested and they come out positive, how do you ensure, or how do you know that you haven't got a huge obstacle there? How do they reporting back big numbers to clinics?
Okay,
and then you're only one phone company, cell phone company out of 3 or 4.
That's correct. Only one. So MTN is only the second largest provider, Vodacom being the first. And MTN graciously gave for free 5% of the inventory. They did that in 2008, they renewed it in 2009, and they're still doing it. So they're giving us free real estate that they could bring real value and sell that to for-profits.
But Vodacom's the bigger one.
Vodacom's bigger, and now they want to come to the party and they want to help. The social text, which is sending messages to person's cell phones, it's the please call me's. So all of you without contracts, or your friends who don't have contracts and tell you that please call me, again, it's tagged onto those messages. It's random. So it's 5% of the 30 million that go out to everyone will have one of these messages that give key information about TB and HIV and say, call the AIDS helpline if you're curious about this particular comment. What we've done is run different subjects. We've had said topics on PMT-CT, on discordant couples, on treatment, on traditional medicine, in different local languages, and look at the response and which ones are more successful. Is it in local language? Is it in English? Is it in Afrikaans? And which types of subjects? So we have all of that extremely well monitored. When the calls are dropped, which language it's driven in, which topics are most interesting, and they call into the cell line, the AIDS helpline. That's a separate project all by itself.
Okay.
The testing itself we want to also use AIDS helpline, but you call a counselor because you've gone in to pick up a test and test. It's a separate issue. And some of the ways we raise awareness around that and make it sexy is you get someone like Bongani to say, hey, I used it, come on, y'all, let's use it. So you use kind of snappy pop culture, media, etc. Use radio. 5 p.m. East Coast radio, it's test time. And walk people through it. There are a lot of different ways you can be creative about how to help people test.
Impumelelo?
I like the idea of self-testing, but I just worry a little bit. I mean, I know you addressed this earlier, but I just worry a bit about the unintended consequences of people testing themselves at home. I mean, South African youth is very terrible in dealing with crisis. They jump off the roof for failing exams. How much more in there to handle something like this? I just worry about it. Have you thought about how do you really creatively and proactively deal with it?
Absolutely, we thought about it. In the first 2 years of it, your question was the most common one asked. How are you going to give support? It's such a sensitive issue to learn you're HIV positive. You're not going to do it with a counselor. People are going to be at home. What I would say is someone who's severely depressed, has a very challenged life, and is on the edge and suicidal, if you send them to a government clinic and give them VCT, that ain't going to stop it. But you said, people live with a lot of challenges and such a people are living with incredible challenges. For the last 2 days, we've been hearing and looking at the challenges people live under. Children live under, adults are live under, incredible hardship. Learning you're HIV positive is just a long string of it ain't so good. So I'm not trying to downplay what it's like to get your status back and learn you're positive, but I'm saying we are offering an option of excellent trained services to answer those calls in a safe environment that the feedback we're getting on the ground is That is the way I want to get my counseling, like that.
And maybe in addition, we always carry, as a healthcare system in South Africa, we carry a tray that says empowerment to patients, and we have carried it like this. And when we're ready to give to them, we said, no. This is the time where South Africa has to actually give powers to people, because the system cannot carry them on their back anymore. We are past the stage. We have to be able to trust people that they can do and make decisions that are going to allow them to be empowerment, yes, give.
And my group doesn't want to eat. They are very fascinated by your project. Fatima, you'll be the last one.
Jill, we want to ask you because it's such a simple intervention. What I struggled with, it doesn't tackle the issue of stigma at all. So it takes testing underground, and doesn't mean the next step is that there's a home-based ARV kit and a home-based CD4 monitoring kit. Because at some point you have to come out and get the treatment at the very public health facility.
That you avoided in the first place. Yeah, that was my.
The critical stages in the chain of handling HIV is getting tested. Once you pass that, you go in flagging into the clinic because you already know which people are going to engage. You choose. In the clinic, you can never choose because they say 10 of you go home, 10 of you come see the counselor. It means you're HIV positive. Hey, God. Now, we giving people an opportunity to decide, once they have tested, who am I going to inform, and deal with it, not being overwhelmed by everything happening at once, everybody knowing, now you're knowing, everybody's looking at you. You take step at a time to go to now, okay, I'm ready, I'm done, I understand I have HIV, I'm moving to going to get my CD4 count done at the clinic. Now I'm ready, I know how to deal with it, I've asked questions, I've called the counselors. So in that way, we have allowed people to process this whole thing at their own pace and privacy that they deserve.
Jerry?
Thanks for your spirited presentation. I think I like what you said. It's almost like the Obama machine, using technology to reach people. However, two issues cross my mind. I think it's something that we have to be very critical of. There's what I call responsible leadership and what I call ethical considerations. Now, the ideas of communication is great. The resistance you are facing from cell phone companies is based on the fact that there are ethical considerations with the CASA. Now, I think Fatima raised a very good point. You know, shouldn't you also consider other options to what you are doing in terms of monitoring the impact of when people become positive or negative? That's just my question.
And your question?
So,
Can I take that question too?
My question is also tied to some of what Fatima said, and that is that transition from when someone knows they are positive and they've done their self-test. And I'm just a little bit concerned about how that conversion happens. And I would just like to hear more explicitly if that is something that is dealt with in your test kit or whatever. And then secondly, just on the please call me thing. Usually it's sent by someone to someone who has more airtime than them. And so instinctively, and then the person who sends it doesn't read it. And it's probably, so you don't get it. So the person you're sending it to is probably somebody who's relatively better off than you. And so I'm not convinced that that's the best way to in fact trigger a way for people to think about getting tested. Because the kind of person who, yeah, anyway, I don't know if I can make that point. And I'm just worried again, because it's competing with commercial real estate, you know, LRINs and everyone else, and a small percentage is used for this purpose, and it's random. So I'm not very convinced of how a small percentage of random messages, that is the luck of the draw whether you do or don't get it, as opposed to something that happens pretty consistently, like wallpaper. Every time you switch on your phone, it ought to come. So I'm not.
Okay. So 3 questions. So 30 million messages sent a day, 5% of 30 million is a lot. And it's not reaching every single person. it's reaching only certain people, and it doesn't get everybody to test. There are all kinds of messages. Some of the messages say, losing weight, having night sweats, coughing for more than 2 weeks, call the National AIDS Helpline. So the messages don't say, go get a rapid test. There are all kinds of ways, and this is one method of raising awareness and sending it to someone's handset. Does it reach every single South African? No, but it reaches a lot of them, such that we know a huge percent, 300% more than were, are accessing information. Is it reaching every single person we're targeting? No. It's one method of using technology to supplement something that's not working. And so that's one answer. The answer to, I'm sorry, yours is about considering...
responsible leadership and ethical consideration.
Okay, so is that in regards specifically to the test?
Well, you're using technology and you're exposing to a lot of information which can have also negative impact when they are positive or negative. I'm just saying the reason why you are facing resistance from the cell companies is due to the fact that the negotiations with ICASA has not reached that level yet. How are you going to overcome this?
So actually, the cell phone resistance was Vodacom didn't want to give up any profit. And once they saw that they could get kind of indirect profit by getting good media, then they came to the table. As far as they're being concerned about, you're 100% right that there are challenges. One of the challenges, for example, is the AIDS Helpline got a bunch of calls because if you translate English into Zulu, it's another story. So people will be like, one interesting thing was a woman got a text message and it said, is your partner sick and losing weight? Go for HIV testing or something like that. The man called the AIDS Helpline furious. How did you get my girlfriend's telephone number and how did you know she's positive? And it's like, no. It wasn't, there is confusion that can happen. You use technology, you're gonna get misunderstandings. Last month there was another misunderstanding. A translation issue again into a local language said, if you're HIV positive, I'm paraphrasing, then it's difficult to detect tuberculosis, which is true. It's exceedingly difficult. Usually you test smear negative, and so it's hard to diagnose TB in a person with AIDS. It was misinterpreted by the Department of Health as reading, if you have HIV, it's hard to get TB. And so they were furious, like, who's screening your messages? You use technology, you use different languages and cultures, you send it to a man instead of a woman, and you're gonna get into a mess. Definitely. There are challenges, there are extreme considerations as far as, is it ethical to give into the hands of someone the ability to learn they're HIV positive without a person standing by? There are extremely important issues to consider extremely carefully, and we appreciate that very much, and appreciate your comment because we agree.
Thank you very much, Anisha and Trisha.